Good evening. I'm psychiatrist Jay Fawver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call in the Fort Wayne area by dialing 969-2720, or if you're calling anywhere coast to coast, you may dial 866-969-2720. Now on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at Matters of the Mind. That's all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with an email question I recently received. It reads, Dear Dr. Fawver, do people diagnosed with bipolar disorder also suffer from depression? How are the two different? Well, that's a very good question in the sense that bipolar disorder is a phenomenon where people will have highs in their mood and they can have difficulty with having decreased need for sleep, irritability, impulsivity. They can have trouble with doing things and saying things they ordinarily would not do or say. And it can be very abrupt, and it can go on for 2 to 5 days, sometimes over a week. That's bipolar disorder on the manic side. And then with bipolar disorder, you can go into depressive lows where you crash into lows and you don't want to do anything. You want to sleep all the time. You're socially withdrawn. It's quite the opposite spectrum, or polar opposite of the high. So that's why it's called bipolar disorder. Bi means two, polar means one extreme or another. Depression is where you more often than not will have difficulty with sadness, lack of difficulty, or difficulty with enjoying things, lack of motivation, lack of initiative, and it could go on day by day by day, up to weeks, if not months for some people. So the key from a diagnostic standpoint is to identify who has the manic highs and who has just the lows, because if somebody has highs and lows, we want to give them a mood stabilizer, which would act somewhat as a cruise control for the mood. So if you have bipolar disorder, you want to have a cruise control in the mood to kind of level out the highs and lows. If you have just lows and predominantly depressive spells, you want to have more of an accelerator on the mood. Not something that's going to put you into manic highs, but something that can bring you out of the lows themselves. So with that being said, it's important that we make that diagnostic distinction to try to help people stabilize their mood in the case of a bipolar disorder patient, or try to help them bring their mood up out of the unnatural low if they have pure depression. Thanks for your email. Let's go to our first caller. Hello, Joyce. Welcome to Matters of the Mind. Joyce, you had a question concerning menopause and brain changes.
Yes,
Menopause
I was
will
wondering.
sometimes give difficulty with brain changes, particularly here in the hippocampus. The hippocampus is the library part of the brain. It's right over here in this yellow part of the brain. The brain's kind of shaped like a boxing glove with a thumb out here being the temporal lobe. On the top of the thumb is the hippocampus. That's where the memory and the attention center of the brain can be. So, but mainly it's more like a library of the brain. When you have menopausal symptoms, often you'll have a shrinkage of that part of the brain because this part of the brain is very sensitive to estrogen. With menopause, and the average age of menopause is 51 years of age. We're hearing about it occurring earlier and earlier with a lot of women. But as your estrogen level goes down, you'll have difficulty with absent-mindedness and sometimes memory, because less estrogen is fertilizing this little hippocampus area here. The hippocampus is fertilized by estrogen. It's very sensitive to estrogen in that area. As the estrogen starts to go down, you'll have trouble with memory and some absent-mindedness. Hormonal replacement therapy sometimes is helpful for a while for women, and then you do adjust over the course of time. But what you don't want to do as you're going through menopause, Joyce, would be, for instance, drink alcohol. If you drink alcohol, alcohol is very toxic on the hippocampus. So the combination of drinking alcohol while going through early menopausal symptoms can be very detrimental to your memory. So we are very adamant about telling people, you know, if you're a woman, you want to hold the alcohol consumption to no more than one, maybe at the very, very most 2 drinks, because 2 drinks for a woman is like 6 drinks for a man anyway, because women do not metabolize alcohol as quickly and as well as men will. So 2 drinks for a woman is like the blood level of 6 drinks for a man. So that's why alcohol will be particularly toxic on this particular part of the brain in the hippocampus. But that's the main part of the brain where menopause will affect the brain itself. It has to do with the memory center right there, Joyce. Joyce, thanks for your call. Let's go to the next caller. Hello, Cedric. Welcome to Matters of Mind. Cedric, you want to know, how does how you eat affect your mental health? Cedric, I'd like to be able to say, here's the diet you want to use. And I do hear some professionals say, here's the diet everybody needs. I don't believe that. I think everybody will respond differently based on their diets. And I was just asked over the weekend by somebody at church, will we have genetic testing someday for determining what diet is best for us? And I think we will. The complicated aspect about genetic testing, however, is that there might be dozens, if not hundreds, of genetics that will affect certain symptomatologies, including our lifestyles. So there might be many, many, many different types of ways that genetics will affect what best diet would be for us. So with some people, they'll say they do best with gluten-free diet. Other people will say a low-carb diet. Other people will say ketogenic diet. Other people will say intermittent fasting. And everybody will respond differently. Many people will say a plant-based diet will change their lives in terms of how they feel, physically and emotionally. So I think it's all depending on how you respond to those diets and keep track of how different diets make you feel. Some people will feel lousy if they have refined carbohydrates and they're eating a bunch of chips out of a bag or out of a box. They will feel terrible with that. Other people, not so bad with it, maybe until they get older and it starts catching up with them. If you have insulin resistance where your insulin levels are unnaturally high, they might be keeping your glucose intact for now, but if you're unnaturally elevating your insulin levels, you can have effects on an emotional and cognitive state on your brain. So the bottom line is, Cedric, from a dietary standpoint, you have to find what works best for you. Generally, I'm a big fan of intermittent fasting with a low carbohydrate diet. For most people, that seems to do best for them if they can maintain that type of diet as a lifestyle. Intermittent fasting basically means you skip breakfast and then you go ideally without any snacks after about 6 p.m. So you're basically fasting for about 18 hours and eating over a 6-hour period day by day. Not everybody responds well to that. Some people will find that they overeat during those 6 hours. Other people will say that they are actually less hungry during those 6 hours of feeding. But 18 hours off, 6 hours on works for a lot of people. And if you are especially watchful of how many carbohydrates you're taking in, try to limit the carbohydrates, especially the refined processed foods that for many people just don't do so well from an emotional and a concentration standpoint. Cedric, thanks for your call. Let's go to the next caller. Hello, Robert. Welcome to Matters of the Mind. Robert, you want to know how depression and disruptive mood dysregulation disorder are similar, how they're different. Disruptive mood dysregulation disorder is a disturbance that has been developed for children and adolescents to try to diminish their lifelong diagnosis of having bipolar disorder. In other words, children and adolescents will have mood disruptions that are out of proportion, and they are overreactive and they have difficulty with putting up with things and stress resilience. That doesn't necessarily mean they have bipolar disorder, which, well, technically is going to be a lifelong condition. Once you have bipolar disorder, to some degree, those highs and lows can be problematic for you over the course of time. So disruptive mood dysregulation disorder is a childhood and adolescent condition where you're overreactive and overly aggressive based on circumstances, more so than expected for somebody your age. In other words, it's out of proportion to what it would be. That kind of reaction is out of proportion to what would be expected for somebody your age. Now, depression, sadness, seen in an adolescent or child can be also manifested by irritability, but more often than not can be characterized by social withdrawal, declining academic performances, difficulty with enjoying things, and not communicating as much as what you would expect for somebody that age. So depression and disruptive mood dysregulation disorder are quite different, but the main key with DMDD, disruptive mood dysregulation disorder, is that it'll look more like a bipolar type of phenomenon for people, but it's only diagnosed with children and adolescents. Robert, thanks for your call. Let's go to our next caller. Hello, Joni. Welcome to Matters of Mind. Joni wanted me to elaborate on the lunar phases of bipolar disorder and schizophrenia. You know, it's been speculated over the course of the years, Joni, what kind of correlation is with the phases of the moon to mood swings. And I've seen research all over the place. Some research saying, it doesn't make any difference. Other research insisting that it does. And if you talk to a lot of hospital workers, they will say that with a full moon or a mostly full moon, there are more admissions and there's more erratic behavior. I don't think we have enough evidence out there to say that the lunar phases will affect the mood as they do the waves of the sea at this point, but it's something that's kind of interesting. I've actually seen some people speculate that when there's a full moon, more people are out and about and they're doing things because there's more light outside than nighttime. So if they're out and about in the evening, they're more awake, they're up and around, and if they're up and around at night, they're getting less sleep. With less sleep, that can aggravate symptoms of bipolar disorder and schizophrenia. So there's a lot of speculation about that. I don't think it's necessarily the phase of the moon itself, it's the light that's causing them to stay awake and be up at night. So it'll be interesting to see how that goes, Joni. Joni, thanks for your call. Let's go to our next caller. Hello, Stella. Welcome to Matters of Mind. Stella, you want to know if trazodone is an effective medication for grief. Grief, if it's to the point where it's considered to be major depressive disorder, which is basically pathological or complicated grief, Stella, is a condition where you often have difficulty with sleeping. Many people, as they're going into prolonged very complicated grieving, and they're having day-by-day difficulty with enjoying things, getting motivated, going to work, socializing. They even think about death themselves. When people get to that point in their grieving, they'll often have trouble with sleep. And if you start lacking sleep, Stella, you'll start having difficulty with being able to concentrate. Lack of sleep itself will give you difficulty with judgment because the front part of your brain at nighttime when you're sleeping is resting. If you're not resting the front part of your brain at nighttime, it's like having a cell phone battery that's not getting adequate charge. So your plug-in on your charge on your cell phone is not adequate. That's what happens when you're not sleeping with dream sleep and deep sleep throughout the night. So if you're not sleeping adequately at night, the front part of your brain doesn't get recharged. If the front part of the brain doesn't get recharged, you don't have good attention span the next day, you don't have good judgment, you can't think clearly, and that will in the long run give you more difficulty with mood and mood disturbances. So where does trazodone come with all that? Trazodone comes in with all that because trazodone will specifically affect a couple of the serotonin receptors that allow you to have a nice deep sleep. And that's why we like trazodone for sleep. It was never approved for sleep. It was approved back in 1991, I believe it was, 1991. It was approved for depression, and it was approved for depression at doses between 300 and 600 milligrams a day. We don't use those kind of doses for sleep anymore. We use doses between 50 and 200 milligrams at bedtime for sleep because at low doses, trazodone will help give you a deep, good quality of sleep and help recharge the brain. So if I was to hear about somebody using trazodone for grief, I'd say that's a good treatment if they're having trouble with sleep because trazodone will help normalize your sleep efficiency. It'll allow you to have the deep sleep, the dream sleep, the kind of sleep that you need to be able to recharge your brain to allow you to function at your highest the next day. Grieving is often a time-limited process for people. If you fall into a major depression where day by day you're having trouble with getting out of bed, doing your daily expected activities, and it goes on for over 2 weeks. Sometimes another antidepressant medication can be added. But trazodone in the 21st century is being used more at lower doses, 50 to 200 milligrams at bedtime, mainly for difficulty with sleep, as opposed to how it was originally designed, that being for depression back in 1991. Thanks for your call. Let's go to our next caller. Hello, Gerald. Welcome to Matters of the Mind. Gerald, you want to know, why do your dreams feel like they last all night? They probably just last for a matter of minutes, Gerald, but they're very, very intense in terms of how dreams work. I mentioned trazodone allowing you to have better quality of sleep overall, but basically when you're dreaming, the thinking part of your brain, the part of your brain you're having to use right now to pay attention to what I'm saying, it's fired up right here. It's called the dorsolateral prefrontal cortex, and it's on the left side more than the right side. But this part of the brain right up front here, when you're thinking, focusing, concentrating, that part of the brain is really working. And when it's working all day, it gets tired. So you need to rest it at night. When you rest it at night, that part shuts down. You go into dream sleep. Now, when you go into dream sleep, if you think about it, Gerald, your logical part of the brain's not working. When your logical part of the brain's not working, you go into all this abstract dreaming. It only lasts for a few minutes, but your time perception is way off. So it might feel like it's going on for hours, but when you look at REM sleep, under electroencephalograms for people, or EEGs. REM sleep's only lasting for a period of minutes for people. You tend to have your first spell of REM sleep, most commonly about an hour and a half after you fall asleep. Then as you go through the night, you have more spurts of REM sleep, having the most REM sleep shortly before you awaken the next morning. So as you go through the night, you have more dream sleep, and it goes through the night more frequently and more intensely as it goes on. When you are having your dreams, though, just think about if you awaken and remember your dreams, you're not going to remember them for very long. Your dreams are like a whiteboard. They get erased really, really fast after you awaken. But when you awaken, if you do think about your dreams, often they have to do with something that happened over the past 48 hours. So something abstractly happened within the past 48 hours. Somehow they came back into your head. You're trying to process them to some degree when you're dreaming at nighttime, and that's kind of how they come out. But your dreams are like putting messages up on a whiteboard. They get erased very, very quickly unless you write them down or really put some thought into it or talk about them for that matter. Most of us can't remember our dreams by noon because they've been erased very, very quickly. Thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Fawver, I have an old friend who recently became homeless. I'm worried about the situation complicating his depression. How can I talk him into keeping his appointments? I'm happy to drive him if necessary. If he's having difficulty with depression, as you can imagine, that's probably going to aggravate his difficulty with homelessness. In other words, if you have trouble with depression, you're going to have difficulty finding a job, socializing with people, interacting with people. So depression will aggravate the likelihood of having homelessness because depression will cause you to have worsening judgment in general. So the whole idea of having appointments for treating depression or treating the whole concept of case management when you're homeless, the whole idea there is to try to find you a meaningful place to live and be able to find either through a mission, through an apartment complex, through some kind of government subsidized housing, some place to be able to live. And when people are depressed, they give up on all that. They tend to look at their whole life as being hopeless. And with hopelessness and helplessness, that actually aggravates the likelihood of not only being homeless, but also wanting to take your life. So that whole sense of despair can be problematic, and it's a cascade. So the best thing you can do with dealing with homelessness is to maintain the hope, be interactive with other people, find work, find meaningful activity, find good social contacts, and maintain that kind of network. Thanks for your email. Let's go to our next caller. Hello, Carter. Welcome to Matters of Mind. Carter, you want to know, when you have a panic attack, what's happening to your body and mind? Why does it feel like a heart attack? A panic attack originates usually in this little amygdala part of the brain, up here in the front tip of the thumb, the temporal lobe. The amygdala is the fear, anger, and anxiety center of the brain. So you can feel kind of anxious in some cases, but what really happens when you're having a panic attack, this middle part of the brain on the stem here really gets fired up, and all this norepinephrine gets fired out. When norepinephrine gets fired out, it's like an adrenaline effect. Norepinephrine and epinephrine are chemically related. Epinephrine is often referred to as adrenaline. So what happens is, you have an adrenaline blast within 10 minutes of having the panic attack. Your heart starts racing, you get sweaty, you get lightheaded, you feel like you're going to die, you feel like you need to escape, you can have trouble with tremulousness, cold chills or hot sweats, you can get sweaty all over, you can have nausea, diarrhea, it feels like you're feeling horrifically miserable, and it goes on for several minutes, in some cases for several hours. So for some people, okay, when we hear about a panic attack, we try to sort back. Do you remember anything that actually initiated the whole process of the panic attacks? Because from a psychological standpoint, there's the fight or flight phenomenon where you're in life circumstances where you're backed up into a corner, and because you're backed up into a corner, you feel like there's no way out of the situation. So it's a fight or flight phenomenon. You can either run from the situation or you try to hang in there, and it feels like you're having a heart attack with all these panic attack symptoms. So a panic attack is where you have an abrupt surge of anxiety, and it's an adrenaline rush during that time. Now, when I hear about panic attacks now, Carter, I'm also sorting out, okay, how many energy drinks do you drink every day, if you drink any at all? How much caffeine are you consuming? Could be other factors. I've seen some people with panic attacks who had a heart arrhythmia. In other words, their heart starts fluttering and it goes really, really fast periodically. There's a phenomenon that occurs more with women than men called postural orthostatic tachycardia syndrome, also known as POTS. With POTS, particularly with women, seems to be an autoimmune condition. With POTS, the heart just starts racing really, really fast, and then they get lightheaded. Many women have been referred to me with the symptoms of a panic attack, but as I talk to them, I realize they might be having POTS. So I have them go to a cardiologist. They get this test called a tilt test, and the tilt test will diagnose POTS, and they get the appropriate treatment for POTS. So we have to sort out, okay, what's causing these panic attacks? I think, 20 years ago when people had panic attacks, the thinking was, oh, you're having a lot of anxiety, let's give you Xanax and Klonopin and some medication that will just calm down the anxiety. But I think we need to be more thoughtful in what's causing the underlying panic attacks, and conditions like POTS. They weren't discussed 20 years ago. Now we know all about POTS. We know more about these underlying medical conditions that might be related to panic. High thyroid can cause you panic. I've seen people with low glucose, when they get hypoglycemic, they can have symptoms of panic. So I think we need to, as clinicians, look at the temporal relationship between when the panic attack started, what might have been going on then, and what kind of medical workup has been done to date, Carter. But you're right, it feels just like a heart attack for some people, and hey, we got to assess that too. If you're at risk for having a heart attack, you need to be assessed for that. Carter, thanks for your call. Let's go to our next caller. Hello, Darla, welcome to Matters of Mind. Darla, you want to know what are the signs of paranoid schizophrenia and when it should cause concern. Paranoid schizophrenia is a chronic, lifelong condition, Darla. It doesn't come and go, and if you have it, you want to treat it. It's not unlike epilepsy. When people have epilepsy, they need treatment. You don't just see what happens if they truly have epilepsy. If they have epilepsy, if they've had recurrent episodes of seizures, they need to be on some kind of anti-epileptic medication. Paranoid schizophrenia, as the name implies, paranoid means they're fearful of other people and their intentions. But with schizophrenia, it's a long process, probably develops to some degree in the womb. It has a genetic predisposition. Doesn't affect everybody. There are triggers for schizophrenia that will bring out the psychotic symptoms for some people, not others. But usually when people have paranoid schizophrenia as adolescents, you can kind of see some of the, we call them premorbid signs, where they can have difficulty with social anxiety. They're more withdrawn. They have trouble with hygiene. They might not take care of themselves as well. They're a little bit more apprehensive about the intentions of other people. They take things the wrong way. They might hear voices or hear sounds in the background that nobody else can hear. And they might have some difficulty just with interpersonal relationships and communicating in general. Many people with adolescent premorbid symptoms will be diagnosed with autistic spectrum conditions, and they do indeed have autistic features. But when you have your first psychotic episode where you distinctively hear auditory hallucinations that nobody else can hear, you hear voices talking to you, you have fixed false beliefs, we call them delusions, where people have beliefs that are very frightening to them, and they're not possibly true, they'll have difficulty processing their thoughts. So when they talk to people, they'll kind of go from one topic to another, but they don't flow in their speech. We call that loose association. So these are the kind of symptoms of paranoid schizophrenia that can occur with a psychotic episode where somebody's hearing voices, they're delusional, they're not taking care of themselves, they might even be withdrawing from school or their job situation during that time. With a psychotic episode, it's like a seizure episode. If you have a seizure, you don't want to have another seizure. If you have a psychotic episode, you don't want to have another psychotic episode, because if you have a seizure, the more seizures you have, the more treatment resistant and treatment refractory you become. It's more difficult to treat somebody who's had many, many, many seizures. The same is true with psychosis. If somebody's had 6 bouts of psychosis, they're much more difficult to treat with medication compared to if they've had 1 bout of psychosis. So if you have 1 bout of psychosis, you want to keep those psychotic episodes under wraps and keep them in very, very good control so they don't occur again, because there is, with seizures and with epilepsy, with psychosis, with schizophrenia, there will be recurrent damage to the brain, particularly the front part of the brain, the judgment part of the brain, with each subsequent psychotic episode. And that's why in the 21st century now we have several medications that are long-acting injectable medications, because a hallmark of schizophrenia will be lack of awareness you have the illness. The problem with treating somebody with schizophrenia is they don't realize that they have schizophrenia. So the need for these long-acting injectable medications that are occurring over the course of, they're lasting over the course of 1 month, 3 months, and now even 6 months, they stay in a person's system long-term, so they don't have to think necessarily about taking their medication, and their denial about having the illness won't be so problematic because they have a long-acting injectable in their system. Thanks for your question. Let's go to our next caller. Hello, Sean. Welcome to Matter of the Mind. Sean, you had mentioned your loved one suffers from severe anxiety, and should you be concerned that that might lead to suicide, what signs should you watch for? Sean, if your loved one has a family history of suicide, that's always a risk factor itself. If your loved one has a history of suicidal behavior, him or herself, that's a risk factor. Anxiety, indeed, and insomnia will be risk factors for suicidality. However, there are other factors as well. When somebody gives up hope, that's a key feature with suicidal behaviors. If somebody's giving away their possessions, if they have nothing for which to live, if they have a significant loss recently where they've lost their job or they've lost a relationship, those can all be factors themselves. But Sean, if you have any concerns about your loved one who has severe anxiety, having suicidal thinking, make sure you have that loved one see a primary care clinician or some mental health clinician as soon as possible. Sean, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm psychiatrist Jay Fawver, and you've been watching Matters of the Mind on PBS Fort Wayne, now available on YouTube. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
The preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.